Greetings, everyone. This is Dr. Weaver. I wanted to develop a voiceover, get rid of that, voiceover on one of your clinical pharmacology topics, and that will be anti-hyperlipidemic medications. I think I am currently sharing, so. Let me go ahead and get started because I don't want to keep you long. Let me see. Uh, Hope that is recording that screen over there. All right. Um, all right. So let's go ahead and get started. Hopefully, as I said, this won't take too long. It may be an hour, 15 minutes. That way we can talk about some of the other um, topics that we would generally need a whole lot more time to go through. Maybe even allow you guys to do some presentations, get you up out of those seats, and people just learn differently when they're up and doing it themselves. So anyway, so let's go ahead and get this started. We are in chapter 33 and your introduction to clinical pharmacology. Again, this is Dr. Weaver. Um, let's take a look at the objectives here. They want you to, or you should be able to, at the end of this presentation, compare and contrast cholesterol, your high density lipoproteins or HDLs. I'm sure you guys have heard of some of these before. Low density lipo protein. Those are your LDLs or the bad cholesterol, and your triglyceride levels and how they contribute to the development of heart disease. The next one, or number two, is define therapeutic life changes, TLCs, and how they affect cholesterol levels. And the third one is explain the uses, general drug actions, general adverse reactions, contraindications, precautions, and interactions of antihyperlipidemic drugs. And really take a look at that word. It's a long word, but it's think about so anti will be against, and hyper will be high, lipidemic, and that is high levels of lipids in the blood, right? High levels of lipids, basically cholesterol in the blood. And as you all know, this can lead to coronary diseases or cardiovascular diseases, along with even strokes when you think about it, because the arteries are basically being clogged up with all the plaque from the cholesterol. And of course, you guys will be working on the pre-admission areas of this discussion, and their nursing diagnoses. Take a look at that, as well as examining ways to promote optimal response to the medication, and especially how we manage the adverse reactions, as well as educating these patients. All right. All right. So, prevention as a means of treatment is a concept used in cardiac health. All right. And we do this by reducing lipid levels in the circulation of those patients, those patients or those populations that don't actually have any current symptoms. Um, and we can reduce the need for more aggressive medications and interventions later on if we can intervene early enough. Now, when therapeutic or lifestyle interventions are not enough, for example, weight loss, exercise, diet, and so forth, then we have to use the anti-hyperlipidemic medications um, as one of these prevention tactics available in our healthcare system. And so, if lifestyle changes doesn't work, then we have to go with the drugs. And we're still doing them together, of course. All right. Now, as far as lipid control, all right. So, atherosclerosis, that's a term I need you guys to really understand. Athero would be the plaque itself, and the sclerosis would be the hardening of the arteries. So you have this plaque buildup, and that also leads to the arteries becoming less flexible or pliable. All right, but atherosclerosis is considered to be a major contributor to the development of a heart disease, particularly those who develop an AMI as well as a stroke. Now, it is a disorder in which lipid, be that fat or fat-like substances, they accumulate on the lining of the blood vessels. Right, that's the intima portion of the blood vessel. In other words, if this is a blood vessel, it would be the inner lining of the blood vessel. You have these fat deposits that are accumulating in that area and eventually producing degenerative changes, and eventually it will obstruct the flow of blood to the different organs and tissues. Now, the two lipids in our blood are cholesterol as well as triglyceride. Serum cholesterol levels above 240 milligrams per deciliter and triglyceride levels above 150 milligrams per deciliter. This is how we measure these the cholesterol, if you will. We refer to this as hyperlipidemia, high levels of lipid in the blood. All right, and of course, this is associated with atherosclerosis. Now, triglycerides and cholesterol are fats that are insoluble in water, meaning that they don't dissolve in water, all right, or any liquids, if you will. Now, for these fats to be transported throughout the body, in order to transport the triglycerides and the cholesterol throughout the body, they have to be bound to a lipid-containing protein, and this is what we refer to as lipoproteins. In order for these the cholesterol and the triglyceride to move about the body within our bloodstream, that is, it has to be attached to a protein, and the protein helps it to be delivered wherever needed. Now, although several lipoproteins are found in the blood, this chapter focuses on drugs used to regulate the LDLs, the HDLs, along with the cholesterol levels. That'll be our main topic of discussion. Something else I wanted to point out to you all is as you can see, and again, I'm hoping that you're looking or able to look at what I'm presenting here. This is basically what happens or the problem with atherosclerosis. So typically, all right, so this is the inner lining. Just look at my cursor. This is the inner lining or the intima portion of the artery. All right, and when someone begins to develop all this plaque buildup due to the lipids, if you will, they create this this foam cell of basically from the increasing lipids. All right, and then what happens is that it creates this core. This is the core here, and then this is the smooth muscle cell. So basically, this is basically the fibro fatty plaque, right? And right now, as you look at it, it is very stable, right? The problem is, especially when we get older, and also particularly those patients who have high blood pressure, it has a tendency of having a damaging effect on the blood vessels, and they can cause this once stable liquid cap, if you will, to rupture. All right, you see here is where it has it ruptures this core. It will rupture, and then of course when it ruptures, it is going to, in other words, it's like it's bleeding, if you will, like someone who has a cut. And I believe these little dots here represents the platelets. If not, then it's good representation. Basically, when there's a cut, you guys already know that platelets tend to travel to the site of where the injury is located, and then of course it develops this thrombus, and it is this thrombus that can occlude this blood vessel. And then of course, in the case of a heart, the coronary arteries, someone can develop a heart attack because you're not, let's say if blood is going this direction, right, is going this direction, and you develop that occlusion right here from the thrombus, then all that cardiac tissue beyond that point is not being perfused. Now, the same is true if let's say this was in the brain. Blood is traveling in this direction, and let's say this is an area of an artery that supplies, I don't know, let's say the cerebellum in the brain. All right, and so you have this thrombus formation here, and what happens is blood cannot get beyond that point because of the thrombus. And of course, you have this infarction of let's say, the cerebellum, and then you begin to see certain symptoms that are associated with that part of the brain that has been deprived of oxygen and nutrients, if you will. So that just kind of gives you an idea of what happens, how the thrombus occurs because you have all those platelets that are coming together, that are traveling to that site of injury, and they clump together, right? And when they clump together, they form a thrombus, and but it's like an occlusion or a blood clot, if you will. So I just wanted to explain that particular process, right? Now, your book talks about low density lipoproteins, or those are the LDLs. And these are the bad lipids. These are your bad lipids. So now your low density lipoproteins, what they do is they transport cholesterol to the peripheral cells. All right. And when the cells have all the cholesterol that they need, because remember, our cells also need cholesterol in order to carry out their functions. When the cells get all the cholesterol it needs, any excess or remaining amount of the cholesterol is now going to be discarded into the blood. All right. This is not good. All right. Now, this excess amount of lipids or cholesterol, it then penetrates the walls, the inner part of the arteries, and of course, this is going to create the atherosclerotic plaque formation. All right. So hopefully you guys understand what I just said. Basically, the excess amount of cholesterol that we don't need, well, has to go somewhere, and it tends to go into the walls of the arteries. And again, this is what's going to cause the plaque buildup within the arteries. Now, elevation of the LDL level increases the risk of a heart disease because, again, the plaque builds up within those arteries. They narrow the arteries, or sometimes they completely cause a complete obstruction, essentially, and blood cannot get beyond that point, and the tissue dies, if you will. Now, on the other hand, we also talk about so we just talked about the LDLs, or the low density lipoproteins. Um, the other side of that is your high density lipoproteins, or what we call the HDLs. Um, the HDLs take cholesterol from the peripheral cells, and it transports it to the liver. All right, where the liver is going to metabolize it and also excretes it into our feces. All right, because it will eventually get into our or be directed to the small intestines, if you will, and then that's when it will be excreted in the stool or feces and whatnot. So basically, the HDL, the higher the HDLs, the lower the risk of development of atherosclerosis, because it is not allowing all that cholesterol to stay in the blood in order to get inside of the walls of the arteries. Instead, it's taking it to the liver, it's breaking it down, and then it's being metabolized, and then it's excreted in the stool. And so that just decreases the risk of atherosclerosis. So it is desirable, of course, to have a high HDL. We actually call that the good lipoprotein level. Because of the protective nature of its properties against the development of atherosclerosis, and of course a decrease in the LDL level. That's what the HDLs do. It helps to lower the LDL levels. All right, so we want to see a high HDL level. All right. Um, Now, a laboratory examination of blood lipids, again, is what we call lipoprotein profile. It provides valuable information on the important cholesterol levels. And those cholesterol levels would be components such as your total cholesterol, your LDLs, which is the harmful lipoprotein. But then you have the HDLs, as I mentioned, which is the protective lipoprotein, and then, of course, the cholesterol, excuse me, not cholesterol, your triglycerides. All right. And take a look at table 33.1. It provides an analysis of the cholesterol levels. Now, just real quickly, cholesterol that is transported by the high density lipoproteins. And as I mentioned to you earlier, it's metabolized in the liver, and then it's primarily excreted in the bile. All right. And from there, remember when the bile is stored in the gallbladder, it's the bile is made by the liver, but stored in the gallbladder. And then when we need it for digestion, that bile moves to the small intestine. All right, because it has to emulsify or break down fat. But see, now it's in the small intestine, which means that it is going to be eliminated in the feces at some point, because it is entering into the digestive tract in order to be eliminated by way of the feces. Now, some cholesterol is also reabsorbed in the intestine and recirculated, but the majority is going to be excreted through bile and stool. And this is what tends to lower the cholesterol levels. All right. Now, the HDL cholesterol protects against heart disease. So that's the good cholesterol. So the higher the number in the blood, the better. The HDL level less than 40 milligrams per deciliter is considered low, and also considered a major risk factor for heart disease. But remember, we want it higher. Now, triglyceride levels that are borderline, for example, if they're between 150 and 190 milligrams per deciliter, or what is considered high or above 190 milligrams per deciliter, these might need treatment in some patients. Now, in general, the higher the LDL level, the more risk factors involved. So the greater the risk, the greater there will be a risk for heart disease. Now, other risk factors besides elevated cholesterol levels that play a role in the development of hyperlipidemia are also will also be discussing. All right. Now, we have what is referred to as uncontrolled risk factors, things that just cannot be changed. So those non-modifiable risk factors, age, men who are older than 45 years and women who are older than 55 years. Gender, in women after menopause, LDL levels tend to increase. Family history of early heart disease, if a father or brother before the age of 55 years old, and a mother and sister before the age of 65 years old. These are uncontrollable risk factors. All right. Now, those factors a person can control or change includes, for example, diet. Those who consume less saturated fat and cholesterol in foods, um, they tend to or they can have a lower cholesterol levels. Increased weight can make LDL cholesterol levels go up and ADL levels go down, which is something we do not want. Remember, we want the opposite. We want high levels of HDL, which will in turn cause low levels of LDLs. Right now, physical inactivity, increased physical activity helps to lower LDL cholesterol and raise HDL cholesterol levels. So exercise is very important. Otherwise, inactivity um, will cause um, well, the opposite. It'll cause the LDLs to be increased, and the HDLs will be lower, and so that's not what we want. So we have to encourage activity. Tobacco use also can be modified. Essentially, you stop smoking. Um, all right. Take a look at some of the drugs that we will be discussing in this presentation. We have the HMG CoA reductase inhibitors. You also have the bile acid raisins, the fibric acid derivatives, as well as niacin. We'll be discussing all of those in more detail. All right. Now, the main goal of treatment in clients with hyperlipidemia is to lower the LDLs to a level that will reduce their risk of developing heart or cardiovascular disease. The primary care provider may initially seek to control the cholesterol by encouraging what we call TLCs or therapeutic life changes. This would include things like a cholesterol lowering diet, without the saturated fats and so forth. There's also physical activity that I mentioned, smoking cessation, and also weight loss management. Now, therapeutic life changes, it also speaks to, again, the low saturated fat, the low cholesterol eating plan that includes less than 200 milligrams of dietary cholesterol per day. Now, in addition, 30 minutes of physical activity each day is also recommended for the therapeutic lifestyle change plan. Walking at a brisk pace for 30 minutes a day, 5 to 7 days a week, can also help to raise that good cholesterol, the HDL, and then, of course, subsequently lower the LDL levels. Now, added benefits of a healthy diet and an exercise program includes a reduction, of course, of body weight. Now, if these therapeutic life change activities do not result in bringing blood lipid levels to more therapeutic levels, then the clinician or your primary care provider may then add one of the anti-hyperlipidemic drugs to the treatment regimen. Now, the TLCs or the therapeutic life change activities or plan are continued along with the drug regimen. So it's not like you do one versus the other. You have to continue, or you have to continue the therapeutic life changes along with the medications, and hopefully you will be able to achieve, um, better control. All right, so let's get into one of the first drugs here. This is the HMG CoA reductase inhibitor, and in terms of the actions, we'll talk more about that. All right. Now, in addition to reduction of dietary fat in the diet, especially the saturated fatty acids, the anti-hyperlipidemic drug therapy is going to be used in order to lower the serum levels of cholesterol as well as triglycerides. Now, the HMG CoA reductase inhibitors, we actually refer to these as statins. Right. And these are what is referred to as the first line drug of choice to lower lipid levels. These are the first drugs that providers are going to go after or prescribe for patients. The target LDL level is less than 130 milligrams per deciliter. That is what we're trying to, that's the goal, what we're trying to get to and or achieve. Now, if the response to behavior modification and drug treatment is adequate, then the physician will monitor the lipid levels at least every 4 months, just to make sure everything is still on track. On the other hand, if we have an inadequate response, then the physician will add another drug or combination of two drugs to the treatment regimen. And you can take a look at table 33.2 for those combination drugs that are currently on the market in order to treat hyperlipidemia. Right. So essentially, they just have to go with a couple of drugs because the lifestyle changes, along with the one antihyperlipidemic drug, is just not accomplishing what we would like to see. All right. Now, three classes of anti-hyperlipidemic drugs are currently in use, as well as a few miscellaneous hyperlipidemic drugs that we'll also be discussing later on. So the various anti-hyperlipidemic drugs decrease cholesterol and triglyceride levels in several ways, and of course, we'll be we'll be delving more into that. Now, although the end result is a lower lipid blood level, each of these drugs have a slightly different action that actually reduces the lipid levels. All right. Now, the anti-hyperlipidemic drugs, in particular the HMG CoA reductase inhibitors, are typically referred to again as statins. All right. This nickname actually comes from the fact that generic drugs in this category all end in statin. Right. When you look at these words, you'll see the statin name or next to or at the end of these drug names. So again, we refer to them as statins. Right. Now, normally the HMG CoA, we call it the HMGA, uh, excuse me, CoA reductase. It is an enzyme. All right. So we're not talking about the inhibitor right now. We're just talking about the enzyme and what the enzyme does. So the HMG CoA is a reductase or reductase rather. It is an enzyme that is a catalyst. In other words, it causes something to happen in that it helps to manufacture cholesterol. All right. So the HMG CoA is an enzyme that helps to manufacture cholesterol. So in your mind, you're already thinking to yourself, well, then if that's the case, if this drug, or rather this enzyme, helps to create or manufacture or make cholesterol, then we need an inhibitor. So essentially, we're talking about this HMG CoA inhibitor or reductase inhibitor. So in other words, we need to block this enzyme, and so that's what we'll be talking a bit more about. So these drugs appear to have one of two activities. More specifically, inhibiting the manufacture of cholesterol or promoting the breakdown of cholesterol, because we need to either break down the cholesterol, or we want to inhibit its manufacture of cholesterol. Now, either drug activity will lower the blood levels of cholesterol, the LDLs, and as well as the serum triglycerides. All right. Now, examples of these drugs can be found in the summary drug table that deals with anti-hyperlipidemic drugs. So make sure you take a look at that. Now, to explain this more simply, the HMG CoA reductase is like a machine in the body that helps to make cholesterol, right? And we do need some cholesterol, right? But when someone has some kind of pathology going on, then you're producing more cholesterol than you need. Right, which is dangerous, can lead to the cardiovascular issues that we were talking about. Right. So basically, this machine, this reductase enzyme, HMG CoA reductase enzyme, it basically speeds up the process of making cholesterol, but it doesn't get used up itself. In other words, the enzyme doesn't get used up. The enzyme itself remains the same. It doesn't get used up, in other words, but it just keeps the process going in terms of making cholesterol. Right. Now, statin drugs work by turning off or slowing down this machine, this HMG CoA reductase, which acts as a machine. The statin drugs either turns it off or slows it down. Right. So the body, in this case, will make less cholesterol because we're either turning it off or slowing it down. And of course, this will aid in lowering the cholesterol levels in the blood. Hopefully that makes sense. It's kind of one of the reasons why I wanted to do this presentation on this particular drugs, because they're not really all that complicated per se, but it'll give me a little more time to really discuss it and try to break it down as much as possible, hopefully. All right. Now, statin drugs, along with diet restricted and saturated fats and cholesterol, are used for treating hyperlipidemia, obviously, also for primary and secondary prevention. As far as primary prevention of coronary events, so in other words, you have these patients who have hyperlipidemia as far as primary prevention, but they don't have any clinical evidence of coronary artery disease yet. So we refer to that as primary because they're not presenting with any symptoms yet. All right. And it is important, this primary prevention is important because it can help to reduce the risk of myocardial infarction and death from other cardiovascular events, including strokes, TIAs, and also cardiac revascularization procedures. In other words, if the artery clots off, with the this plaque buildup, we have to revascularize it with maybe stents or something like that. And so, with the primary prevention, we want to intervene early so that it doesn't lead to all these health concerns, if you will. Now, as far as the secondary prevention of cardiovascular events, what happens here is you have these patients with hyperlipidemia with evidence of coronary artery disease. Um, and what we're trying to do at this point, so we're aware that they have the disease, this plaque buildup, this hyperlipidemia. But what we're trying to do now is just reduce their risk of coronary death. Or we're trying to basically slow down the progression of coronary atherosclerosis. Again, this is secondary prevention, and this hopefully will reduce the risk of death from a stroke, TIAs, as well as having to undergo a myocardial revascularization procedures such as a heart cath with a stent. Right. So hopefully, with the secondary prevention, which essentially just says they have the disease, we're aware of it now. So what can we do to slow it down or to reduce any risk? You know, of strokes, heart attacks, death, and so forth. And so that's the idea behind that. So make sure you guys pay attention to the primary prevention, secondary prevention. They like to ask you questions or give you an example and want to see if you know the difference between the two. And just remember, with primary prevention, there's no clinical evidence of disease, whereas though secondary prevention, there is evidence of the disease. In the primary prevention, we're trying to employ certain treatment regimens or preventative regimens that will where it won't lead to this building up of plaque, if you will, hyperlipidemia, causing an increase in plaque in the coronary or in the arteries, if you will. But the secondary, it's already evident, and we're just trying to essentially slow it down. All right. Take a look at the adverse reactions for the HMG CoA reductase inhibitor. Remember that HMG CoA reductase is an enzyme that causes cholesterol to be made, but now we're trying to inhibit it. All right, hence the term inhibitors. Neuromuscular system reactions, you have headache, dizziness, insomnia, as well as memory or cognitive impairment. All right. The adverse reactions with these drugs are relatively mild and transient, and they do not require discontinuing therapy. You know how some drugs it requires the clinician to discontinue it because of its side effects. Like when you think about um, um, what is it, like lisinopril, an ACE inhibitor, when patients start coughing or the angioedema, we discontinue the medication. In this case, with this particular drug, it is not likely that it will have to be discontinued. As far as the GI system reactions, flatulence or gas, abdominal pain, um, cramping. They like to ask you questions about cramping with this particular drug. Uh, and also that's something how it affects the muscles as well, like rhabdomyolysis or myopathy, because it's toxic to the muscles. Constipation, nausea, hyperglycemia in non-diabetic patients, and that's because typically this drug causes insulin resistance. Right? If you have insulin resistance, this drug can actually cause blood glucose levels to increase. All right. Asian clients are at risk more so from developing these adverse reactions. All right. There's a drug called rosuvastatin. In higher doses is linked to risk for serious muscle toxicity or the myopathy, rhabdomyolysis in certain populations. And so you have to watch for, especially if they begin to complain of cramping, if you will, muscular cramps. Then may need to think about de-seeing the medication at that point. They do allow for a much lower dosage to start off for those individuals who don't really require aggressive cholesterol reduction, measures. or those who have predisposing factors for myopathy or toxicity to the muscles, they may start them off with this drug at a much lower dose and then go from there, see how the patient tolerates it. Um, right, and I've already mentioned this. This is something that they really like to ask you a lot about with these statin drugs, the leg pain or cramping, and the rhabdomyolysis. So make sure you make a note of that. All right. As far as contraindications for this medication, known hypersensitivity, of course, liver disorders. This medication is heavily metabolized in the liver. So we certainly don't want to give it in a patient who already has a liver disorder. It is pregnancy category X. That's the highest level of a warning in pregnant women, as well as lactation. All right. Now, in some individuals with diabetes risk factors, these statin drugs may also elevate the blood glucose and hemoglobin A1C levels. Um, we must use caution in using this medication in the following patients. Those with diabetes, again, they have a decreased insulin, or their cells have a decreased insulin resistance, and so they tend to have higher blood glucose levels. Alcoholism, remember this drug is metabolized heavily in the liver. So use with caution with those patients. Non-alcohol related liver disease. So those patients who they have liver disease, but it doesn't have anything to do with alcohol. So we have to be careful with those patients. Acute infection, hypotension. Remember, if somebody has hypotension, then they are not perfusing their organs and tissues, and especially if you're not perfusing your liver. Remember, the liver does a lot of the work here, and so if you have a patient with hypotension, it can potentially cause some pretty significant problems because the liver won't work very well if it's not being perfused very well. Also use cautiously in trauma patients, those with endocrine disorders, visual disturbances, as well as myopathy. Now, again, remember, don't get it confused. If it's contraindicated, you cannot give it at all. But if it's used with caution, it means that you can give it, but you have to take into consideration these various health issues that are listed here and really watch these patients. All right, and these are just your interaction tables, and so just take a look at this. So, for example, your microlides, your erythromycin, clarithromycin, we use these drugs to treat infection. And so if you give these HMG-CoA reductase inhibitors with these drugs, it will cause an increased risk of severe myopathy or rhabdomyolysis. So it can affect or become very toxic to the muscles, if you will. Um, so again, take a look at um, your interaction tables. Right. All right. So this is another um, inhibitor type of drug that we need to discuss. All right. Now, this medication is called the pro-protein convertase sub ptyrosin kexin type 9, the PSK9 inhibitors. Now, these are a class of LDL lowering drugs used for clients who have genetic familial hyperlipidemia or at very high risk for cardiovascular disease or developing cardiovascular disease. They're just high risk. So if they have a familial history, you have folks in the family who have the high risk for developing high blood lipid levels, as well as those who are high risk of cardiovascular disease, this drug would be appropriate for that patient population. All right, and again, we're talking about the inhibitor. Um, so therapy for genetic familial hyperlipidemia begins with we want to change the diet initially, all right, and also statin drugs. So we're doing both. Now, if this is not successful, then the drug is changed to this PCSK9 inhibitor. So let's talk about what does PCSK9 do? Not the inhibitor, but this is an actual enzyme. So this PCSK9, it is an enzyme that binds to those LDL receptors that are located on the liver. All right, and it prevents. So when these enzymes stimulate or occupy those LDL receptors on the liver, all right, now just follow me. What they would do is prevent the it prevents the cholesterol from being removed from the blood. And if it prevents this cholesterol from being removed from the blood, it is going to increase the LDLs, or the uh, uh, well, the LDLs, the that type of lipids, if you will. Anyway, so it will cause it to increase, in other words. All right. So now, so these inhibitor drugs, they refer to as monoclonal antibodies. Don't be too concerned about that. But what they do is they block the enzyme process, or those receptors that are located on the liver. It blocks it, and of course, if it blocks it, then the LDLs won't remain in the blood. It will thereby lower the LDL cholesterol. All right. So again, this PCSK9 is an enzyme that binds to these receptors that are located on the liver. When that happens, then it is going to prevent the cholesterol, the LDL, from being removed from the blood. All right, and this is what causes the increase in the LDL. And so, what we want to do is we want to inhibit that enzyme. All right, and if we can inhibit the enzyme, then we're able to remove the LDLs from the blood, and thereby achieving lower LDL levels, which, of course, as you know, that's what we want. We want lower LDL levels. That's the goal. Now, the two drugs that your book talks about is your Praluent. That's more the trade name, of course, and the Repatha. So take a look at those. Take a look at the generic as well as the trade names, and they are approved for this particular treatment. Now, these drugs are actually administered subcutaneously, only once or twice monthly, and they have been successful in lowering the LDL cholesterol. However, they are expensive. It costs roughly $14,000 annually. Now, this is compared with the yearly cost of a statin drug at approximately $250 per year. So, if you look at the cost, we already know it just boils down to the money, and so they're likely going with the regular statin type of drugs. These two drugs that I just talked about, they do have the possibility of causing cognitive adverse reactions, and so probably all the reason why you should go with the regular drugs as opposed to this very expensive drug. $14,000 is just really ridiculous. All right. All right, so the next cholesterol lowering drug is your bile acid raisins. Bile acid raisins. All right. Now, you guys have heard of bile. We know that bile is manufactured and it is secreted by the liver. and then it is stored in the gallbladder until we need it, especially when we eat foods that are that contains fat. Now, what this bile does is it emulsifies fats as well as lipids as these products pass through the intestine. And so when we consume a meal and foods that contains fat and also cholesterol, as they pass through the intestine, they're going to be broken down. All right. Now, once emulsified fats and lipids are readily absorbed um, into the intestine, or the fats and the lipids, once they're broken down, then they can now be absorbed in the body. All right, by way of the digestive tract, and that's we want some of it, but not as much, and so there are ways to decrease the amount that is absorbed, and that's what we're talking about here. Now, the bile acid raisins, what they do is they bind to the bile acids to form what is referred to as an insoluble substance that cannot be absorbed by the intestine. All right. So we take this drug, this bile acid raisin. All right. And when we give this drug to patients, it is going to bind to the bile acids that are produced by the liver. All right. And when it talks about in order to form an insoluble substance, when it's insoluble, what you want to take away from that is it cannot be absorbed in the intestine. All right. And instead of it being absorbed in the intestine and returning back to the body, instead it is not absorbed, stays in the intestine, and is excreted with the feces. All right. So it comes out in the feces. All right. So with this increased loss of bile acids, the liver is going to now turn to the cholesterol that one has in their blood and try to manufacture more bile. All right. See, the idea is we're trying to make it where the body has less bile, and then the liver is going to try to make more bile. All right. And when it does that, um, in order to make bile, the liver has to have access to that cholesterol that is already circulating in our bodies. And so it takes that circulating cholesterol, right, to try to make more bile. And of course, that is going to in turn lower our cholesterol level. Right? I hope that makes sense. Right? Basically, we're losing all these bile acids in the intestine, and the liver is saying, "All right, I need to produce more bile. So let me access the cholesterol because I need cholesterol to make bile. That's what bile is made of. It's made up of cholesterol. So I'll borrow some of that cholesterol from the body, and I'll make more bile, right? So I'm taking away the supply of cholesterol from our blood system, if you will, and that'll make the cholesterol levels decrease. All right. Another way to explain this is so bile is a substance made by the liver and is stored in the gallbladder. It helps break down fats so that the body can absorb them. We break down fats and then we absorb. We break down fats or bile breaks down fat in order for it to be absorbed in the body. Now, the bile acid raisins are the medications that stick to the bile in the intestines, and it is going to prevent this bile from being reabsorbed. And instead, this bile get removed in our feces. Right now, since the body needs bile for digestion of fats, the liver is going to use cholesterol that is in the blood to make more bile. And if I need to make more bile using that cholesterol in the blood, I'm going to lower my cholesterol levels. That's pretty much how that works. Hopefully that makes sense to you. If not, we can talk about it more in class. Right. Now, the bile acid raisin are used to treat hyperlipidemia in clients who do not have an adequate response to diet and an exercise program. And so they'll add this particular medication to the treatment regimen. Also, is used for gallstone dissolution in clients where they cannot have a cholecystectomy. Some patients have gallstones and they have to have a cholecystectomy or removal of the gallbladder. But if they can't have the surgery due to whatever reason, maybe they're just not stable enough, then this drug is given to dissolve the gallstone. All right. Um, and um, so they use it for that purpose. It says here gallstone dissolution in clients with surgery, cholecystectomy is not recommended. So these patients they can't essentially they can't have a surgery. That reads really funny though. Also, patients who have pruritus um, associated with partial biliary obstruction, then they should take this drug called cholestyramine only. This is one of the cholesterol lowering drugs. But in order to receive this drug, it has to be a partial biliary obstruction. If it is a complete biliary obstruction where bile cannot come down those ducts, and in order for it to reach the small intestine, if there's a complete blockage, then you do not want to give this particular drug to those patients. All right. Some of the adverse reactions, constipation, may be severe and occasionally result in fecal impaction if this constipation is significant enough, aggravation of hemorrhoids, abdominal pain, flatulence, as well as nausea. Also, there's increased bleeding tendencies related to vitamin K malabsorption and vitamin A and D deficiencies. And so those are the um, reactions you might see, the bleeding, increased bleeding tendencies. But again, it's because they cannot absorb vitamin K. Uh, let's see. Contraindications and precautions. Now, the bile acid raisins are contraindicated in those patients with known hypersensitivity to the drug. The bile acid raisins are also contraindicated in those with complete biliary obstruction, and that's what I was talking about. So you don't want to give it in those particular cases. These drugs are also used cautiously, meaning they can be given, but with caution, in those patients with diabetes, liver, peptic ulcer disease, kidney disease. Right now, bile acid raisins should be used with caution in pregnant women, as well as those who are lactating. Right, because there's decreased absorption of vitamins. You may not be able to absorb vitamins, and of course that can affect infants. All right. So take a look at your interaction table. So for example, the anticoagulants, we know that it is commonly used to prevent blood loss. And what effect does it have when it's given together? So it decreases the effect of anticoagulants, and more specifically, the cholesterol-lowering drug, cholestyramine drug. This will cause a decreased effect of the anticoagulant. So in other words, these patients may develop blood clots if given together. All right. So they're very particular. They're talking about the cholestyramine. These in these two boxes here. There's also it interacts with fat soluble vitamins A, D, E, and K, or ADAC, as well as folic acid. And these are your supplemental, or rather nutritional supplements. And basically, given together with this bile acid raisin, it can reduce absorption of these vitamins. And of course, as you know, we need these vitamins, and so it would decrease the absorption thereof. Take a look at that one as well. This one is easy to understand because it says decrease serum levels or decrease GI absorption of these drugs when given with bile acid raisins. So these drugs may not be um, absorbed very well, or these patients may develop, if they're not absorbed very well, then you're going to have decreased blood levels, especially like your digitalis, your antibiotics, and so forth. All right. So take a look at that. We're almost done, actually. All right. So now we have I think this is the third one, the fibric acid derivatives in terms of its actions. These are known as fibrates. This is the third group of anti-hyperlipidemic drugs, and these work in a variety of ways. Now, the phenofibrate acts by reducing very low density lipoproteins. We also refer to these as the VLDLs, and they stimulate the catabolism of um, triglyceride-rich lipoproteins. And of course, this will result in a decrease in plasma triglycerides as well as cholesterol. So again, this phenofibrate, it reduces the very low density lipoproteins, but it also causes the catabolism or the breaking down of the triglyceride-rich proteins. And of course, we can achieve a lower triglyceride and cholesterol levels. Now, the GIM fibrosine increases the excretion of cholesterol in feces. So if I can excrete the cholesterol in feces, then I don't have as higher levels in my blood system. Also reduces the production of triglycerides by the liver. So it doesn't allow the liver to produce as much triglycerides. And of course, this will in turn lower the serum lipid levels. So that is what that drug actually does. In terms of use, now, although the fibric acid derivatives have anti-hyperlipidemic effects, their use varies depending on the drug itself. So they don't quite all work the same. So, for example, the GIM fibrosine is used to treat individuals with very high serum triglyceride levels who are at risk for abdominal pain, pancreatitis, and also those who do not experience a response to dietary modifications. All right, they don't respond well to uh, the diets that should lower cholesterol values. Now, the phenofibrate is used as an adjunctive treatment for reducing LDLs, total cholesterol, and triglycerides in patients with hyperlipidemia. In other words, it's used along with um, like diet modifications, exercise, and lifestyle changes. So it's an adjunctive treatment modality for this. In other words, the drug itself cannot do it by itself. So we need, again, those TLCs that we talked about. So the adverse reactions also associated with fibric acid derivatives, nausea, vomiting, and GI upset, diarrhea, cholelithiasis or stones in the gallbladder, as well as cholecystitis, which means inflammation of the gallbladder. So lithiasis is a stone in the gallbladder, and cholecystitis is an inflammation of the gallbladder. So don't get those confused. Now, if cholelithiasis or gallstones is found, the primary care provider may discontinue the drug. Because I believe that one would be contraindicated with those particular patients. Now, the fibric acid derivatives are contraindicated in patients with a hypersensitivity to the drug, but also those with significant hepatic and renal dysfunction, as well as those with primary biliary cirrhosis, because these drugs may lead to an increase in elevated cholesterol. So you don't want to give it in those patients. And of course, those who are lactating and pregnant women, we want to use the drug with caution. Take a look at your interaction table again. Anticoagulants, it prevents blood clots, but given together, you have enhanced effects of the anticoagulants, which means that these patients might bleed. If it's given with cyclosporin, we use these drugs for suppression after organ transplantation, liver transplant, kidney transplant, and so forth. We give these types of drugs cyclosporin. But if we give it with this fibric acid derivatives, it can cause an increased risk of rhabdomyolysis. So you have this toxicity to our muscles. And so you have to watch these patients. All right, and just take a look at the rest of these. All right, and so these are the miscellaneous anti-hyperlipidemic drugs in terms of their actions are concerned. Niacin. Well, some of the drugs would be your niacin, your bempedoic acid, as well as your ezetimibe, something like that. As far as actions are concerned, the mechanism by which, so we don't know why niacin lowers the blood lipid levels fully. It's not fully understood. So that's the one side of that. Now, the bempedoic acid, this drug actually inhibits the synthesis or the making of cholesterol in the liver. So that's how it works. And the ezetimibe, it inhibits the absorption of cholesterol in the small intestine. All right. And this will lead to a decrease in cholesterol in the liver. Right. Because if you don't absorb it in the intestine, it's not going back in the body. Instead, it's going out in the feces instead. All right. Now, niacin is used as an adjunctive therapy for lowering very high serum triglyceride levels in those patients who are at risk of pancreatitis, right, which is an inflammation of the pancreas, and also for those whose response to dietary control is not adequate. Now, the bempedoic acid and the azitemide, they're typically used in combination with other anti-hyperlipidemic drugs in order to lower the lipid levels. And so you have this combination. All right. In terms of the gastrointestinal reactions, your nausea, vomiting, diarrhea, abdominal pain, getting close, people. Other reactions, you have severe generalized flushing of the skin. That's especially associated with the niacin. Sensation of warmth, severe itching or tingling, and generalized muscle aches and flu-like symptoms. That last one, they typically, again, like to ask these type of questions with these anti-hyperlipidemic medications. In terms of your niacin is contraindicated in patients with active peptic ulcer disease, hepatic dysfunction, as well as arterial bleeding. And of course, the bempedoic acid and the azitemide is contraindicated in your pregnant and lactating women. Now, niacin is used cautiously in patients with renal dysfunction, high alcohol consumption, unstable angina, gout, as well as pregnancy and lactating women. Now, with this drug, there's an increase in uric acid levels, so that's why we wouldn't want to use it with gout. because with gout, that's actually what the primary issue is. This increase in uric acid that forms that gets into these large joints and forms crystals, causing significant pain. Um, there's also a possibility when this drug is given that it may result in a tendon rupture that can occur with the bempedoic acid. So think about tendon risk of tendon rupture and the bempedoic acid. So that's something that you might see again as well. And folks, that is actually it. Let me see if there's anything here. So we have our pre-admission assessment, the vitals to weight, inspect the skin and eyes for evidence of xanthomas. Look at our labs. We want to know what our lipid profile levels are, liver function, since it is heavily um, metabolized in the liver, blood glucose and hemoglobin A1C levels, since this drug can cause hyperglycemia. Let's see, subjective, dietary history, medical history, cholesterol, and cardiac issues that we need to know about. We always want to make sure that we know what herbal medications, supplements, and other drugs these patients are taking, because we want to know how they might interact, or if they do interact with these cholesterol lowering drugs. So we always want to frequently monitor the cholesterol and triglyceride levels. We want to look at the liver function test. We also call liver function tests LFTs, liver function tests. That's what these are, your liver function, the bilirubin levels, and so forth. Periodic lipid profiles is also good to know, because we want to know if the medications are actually lowering the cholesterol. These are our nursing diagnosis: constipation, malabsorption, altered skin integrity, nausea related to antilipidemic drugs, and also injury related to dizziness. All right, so take a look at that. Um, explain drug regimen and possible adverse reactions. That's a given. Emphasize the importance of following printed dietary guidelines, and hopefully that will help to decrease the lipid levels. Discuss with the client minimizing high fat bedtime snacks due to statins not absorbing well when administered with high fat meals. That's very important. Also, it's something I wanted to tell you all, although I didn't see it in this presentation or your book. They typically give cholesterol medications at about 9 o'clock at night, because that is the time when your liver produces quite a bit of cholesterol. So if they can minimize the production of the cholesterol, then patients will have a low cholesterol level. So that's something to keep in mind. I'm not sure if they'll ask you any questions about it, but just in case. Think about our patients with constipation, because some of these drugs can lead to that. So especially your older patients, you want to make sure maybe you're instructing them on foods that are high in roughage, right? Fiber, if you will. You have to inform them to drink more fluids if it's not contraindicated. Exercise, of course, can help. Stew softeners might be necessary, and then how to take it. But the high fiber diet is really preferable. Malnutrition. So when bile acid raisins are used for long-term therapy, administer vitamin A, D, and water-soluble form, or you either administer it as a water-soluble form or parenterally. Because remember, this bile acid raisins, it takes materials out of the intestine and into the feces, and it'll take the vitamins with it. So we need to make sure they have proper vitamins. Skin integrity, educate the client taking niacin that they may experience moderate to severe generalized flushing of the skin, sensation of warmth, and severe itching or tingling. So really pay attention to this niacin. You may see that one again on your test. Advise the client to contact the primary care doctor if skin reactions are severe and cause discomfort. Instruct client to, this is nausea, take the drug with a meal, or provide client with several small meals rather than 3 large meals is helpful with the GI symptoms, and notify provider if nausea is severe or if vomiting occurs. injury. Watch these clients closely for falls. Maybe a home assessment would be necessary to make sure that there's nothing in place that would cause falls. If they're in the hospital, place the call light nearby. Ambulate them as needed with assistance. So instruct them to call for assistance. That's a question. Potential complications, vitamin K deficiency. So include foods high in vitamin K in the client's diet. So teach the client to monitor for bruising. Parenteral vitamin K may be also indicated. They may have to give vitamin K as an injection uh, because of these drugs. They cause antihyperlipidemic drugs cause a deficiency in vitamin K, which is required for stopping bleeding. All right, and so if deficient, um, then these patients uh, they can uh, they can bleed. In other words, all right. Um, Rhabdomyolysis, be alert for unexplained muscle pain, muscle tenderness, or weakness, especially if accompanied by malaise, fever. Symptoms should be reported to the provider. As I keep telling you, this could be a pretty big one regarding your anti hyperlipidemic medications. It's all about the muscles and the liver and so forth. All right, educating the family, um, statins inform the client that statins should be taken in the evening or at bedtime. So it is here. All right, I just didn't get to it yet. All right, so yeah, so in the evenings or bedtime. This is when cholesterol is actually made more so in the liver. Do not take statins with grapefruit juice. I guarantee. Well, I can't guarantee you, but that'll likely be on your test. Take antacids at least 2 hours after rosuvastatin. All right, you don't want to give them close together. Teach the client that statins may cause photosensitivity and to wear sunscreen and protective clothing. Self-management skills. Let's see, empower clients to supporting efforts rather than telling them to participate. Encourage clients to reduce their cardiovascular risk by using cardiovascular risk calculator, educational tools on the internet, appropriate for their age, cholesterol level, and blood pressure. So there's just some tools to help them reduce their risk. Bile acid raisins. Take the drug before meals unless otherwise directed. The cholestyramine powder must be mixed with 2 to 6 ounces of water or a non-carbonated beverage and shaken. So this is basically, again, it's a powder. So make sure you pay attention to that as well for testing purposes. Cholesterol granules must be mixed in liquids, soup, cereal, carbonated beverage, or pulpy fruits. And use about 90 mLs of a liquid when you're as far as you know, instructing your patients. Cholesterol tablets should be swallowed whole, one at a time, with a full glass of water. Again, that sounds like something that can be on your test. Do not sip or hold liquid preparations in the mouth. Tooth discoloration and enamel decay can occur. So do not sip or hold liquid preparation. So some of these drugs come in liquids, and so don't hold it in your mouth. They can destroy your teeth. GI symptoms may occur, but usually subside with continued therapy. Gem fibrozil. Teach clients to observe caution while driving or performing hazardous tasks. Notify physician if nausea, vomiting, diarrhea occurs. Niacin, take with meals, can cause flushing, warmth, or itching, a headache. Provider may prescribe aspirin to take 30 minutes before niacin, and this can hopefully minimize some of those symptoms or side effects or adverse effects that you see here. The azitemide, teach clients to take at least 2 hours before or 4 hours after a bile acid sequestrant medication and report adverse effects to the healthcare provider. All right, I think this is that raisin drug that they're referring to. Then, of course, your evaluation. We want to know is it working essentially. So, all right, and that is it. That is it. All right. So, you go back here. I hope to God this thing recorded. All right. For some reason. Oh, let me stop sharing. I'm sorry. That's it. All right. So I'm going to get this uploaded, get it sent out to you all, and hopefully you find it helpful. Thank you.